Hi guys, welcome to the discussion. We're going to talk about acute myeloid leukemia. Now, as compared to CML, this condition would be having a dismal prognosis. In fact, the 5-year survival rate for this cancer is a mere 25%. So let us actually see what really went wrong. One of the biggest problems that we encounter as a physician while managing this patient can be an extremely high TLC count that will contribute to leukostasis, which implies that there would be a sluggish circulation due to increase in the cell count. Secondary to the hyperviscosity, there's a possibility that this guy could be having acute coronary syndrome. They can be stroke-like manifestations, priapism, even in fact, lungs can be involved. So you could be having respiratory distress, and the Glasgow Coma scale of this patient will drop because there was a problem with the brain circulation of the patient. In a multiple choice question, if they ask you regarding leukostasis, then obviously you will answer both for acute as well as chronic myeloid leukemia. But in chronic myeloid leukemia, as I've explained to you, once the patient will go into blast crisis, that is when you would be having a development of leukostasis, where in acute myeloid leukemia, it could be rather early on in the development of the disease. The second big problem that we see with this cancer is possibility of development of DIC, and well, we have a very interesting strategy by which we have been able to curtail the DIC rate in these patients. You see, per se, you will always read in pathology that acute promyelocytic leukemia T15:17 translocation, that is M3 variety of AML, is associated with DIC. What was happening was that we were trying to kill this cancer by cytarabine, and the bad news was because this M3 type of AML is loaded with OIR rods, these OIR rods were triggering DIC. So we decided to change our strategy, because you see, medical science is all about learning and unlearning, and you would be aware from pharmacology that nowadays we use arsenic. Yes, you heard it right. I mean, you read about arsenic as a homicidal poison, but I'm talking about arsenic trioxide and even a vitamin A derivative, Atra, for management of these patients. So lots of interesting things coming on. So keep tuned, and let now look at, once we have talked about the survival rate, why would this tumor be developing? Because the first question that a patient or his son and daughter is going to ask you, why my father, and what really went wrong with respect to my dad that he ended up with development of this blood cancer. In lots of cases, you will be having to sound a little, I would say, casual by saying it is idiopathic, we really don't know, and they are going to make a big face, maybe roll their eyes and say, doctor, you don't even know why the cancer is developing. So that's what happens in about 25 to 50% of cases. Why it develops, we really don't know. But yes, medical science is all about learning facts where lots of things can be idiopathic. So let's look at another scenario where we have found a cause. Like this chap, he could be having a bone marrow failure. Now, when I say bone marrow failure, this chap could be actually having a inherited DNA repair defect that you always read in biochemistry and even in pathology, that is Fanconi's anemia. And then are two very interesting terms which must be given the due respect, not because that they're common, but because they're rare, and our examiners love to ask about rare aspects. So one of them is called as Diamond-Blackfan syndrome. Now, what happens in Diamond-Blackfan syndrome is that these patients will have a possibility of not only developing acute myeloid leukemia, but in the later stages, bone marrow failure would imply they can end up with development of aplastic anemia as well. Contrast this with an alternative term that I'm telling you now. The name is Schwartzman Diamond syndrome. So you can see that this can definitely cause a bit of distress when you're reading it for the first time. So when it comes to Schwartzman Diamond syndrome, this is actually a genetic disorder, autosomal recessive, and this mainly has a tendency to cause damage to the exocrine component of the pancreas. Now, all of you know the fact that exocrine component of pancreas can also be affected with respect to cystic fibrosis. So I want you to remember, whenever you read about exocrine pancreatic insufficiency, just like you guys are comfortable with cystic fibrosis, I have today taught you another disease which will not only be having hematological manifestations, but will also be having an exocrine pancreatic deficiency. In fact, I'll just put the arrow the other way around to highlight that Schwartzman-Diamond syndrome would be having two issues. One, possibility of development of AML, hematological malignancy, plus exocrine pancreatic insufficiency in these patients. And because of the overlapping terms, the examiner can definitely put them and ask them to you in the exam. I would personally suggest you to remember the last one that I mentioned, Schwartzman Diamond. They could be AML, they could even be aplastic anemia, and mainly exocrine pancreatic deficiency. Now the third cause why this could be developing, though it will sound like a repetition to you at the moment, but what I'll do here is I will mention causes where you have defective DNA repair over and above the aspect of Fanconi's anemia that you anyway tend to remember. So all of you have read regarding Bloom syndrome. And then is a neurocutaneous disorder in which there will be involvement of the spinocerebellar pathways. So there would be a neurological manifestation because I said neurocutaneous, the neurological feature would be development of ataxia. If you have a look at the white of the eye of these patients, that is in the sclera, you will be able to see a leash of dilated blood vessels. Now, the way I'm sitting, a little away from the camera, or the way you're looking at me, I mean, you can make out my eyes, but you can't make out the blood vessels in the white of my eye, that is in the sclera. But in these patients, very thick dilated leash of blood vessels can be seen, that is telangiectasia. And along with this, I said these patients would be having spinocerebellar pathway damage, and over and above this, lymphoreticular malignancy. So three things I'll repeat once again. Neurocutaneous is 2. Neurological would be spinocerebellar pathway damage, telangiectasia and the white of the eye, dilated blood vessels, leash of blood vessels would be seen, and then chances of development of lymphoreticular malignancy, AML, can be associated with these patients. The fourth cause is relatively easier to remember and most people are very comfortable with it from pathology also. That would be trisomy 21 Down syndrome. For this, they would definitely love to ask you regarding the subtype that will be encountered. That would be acute megakaryoblast leukemia, which is also written as M7 variety of acute myeloid leukemia. And the problem in these patients would be with respect to a specific gene, because I think M7 everybody knows, megakaryoblast leukemia everybody knows. What he can definitely incorporate is the gene defective in this case. So a bit of data crunching to be done here. That is GATA1 gene is involved with respect to patients of Down syndrome who will end up with AML. You see, the point is the commonest hematological malignancy in Down syndrome is also acute lymphoblastic leukemia, ALL. But if they ask you subtype of AML, see, there are two questions. One is going to be which is the commonest hematological malignancy. Down syndrome is a child. Children anyway have ALL. But if he specifies which subtype of acute myeloid leukemias found in these patients, what is the associated gene, then you will definitely be ready with the answers. And point number 5 is again important from the exam perspective because I'm going to be describing secondary malignancy to you. What I mean by the word secondary malignancy is that this patient has been exposed to an anti-cancer drug. The good news is the anti-cancer drug has resolved the initial primary malignancy, but this chap, due to exposure to this anti-cancer drug after few years, look at the bad news that I'm saying, this person was exposed to this anti-cancer drug. The primary malignancy improved, no issues. But now there is a new cancer that will develop in these patients, and which is that one, the topic of interest, acute myeloid leukemia. It usually takes approximately 4 to 6 years for the acute myeloid leukemia manifestations to start occurring in this patient post-exposure. Mark my words there. I did not say AML will take 4 to 6 years to develop. AML has a stormy onset. Manifestations develop within 3 months, and the person would be from a very fit person who can run 5 kilometers to end up with a bedridden patient with bruises all over his body, bleeding from his nose, as is the standard presentation of acute leukemia. So AML itself has a stormy onset, but here what I said was once he's exposed to the anti-cancer drug, after 4 to 6 years of exposure to this anti-cancer drug, this chap would end up with development of AML. And he'll ask you, why would this be happening? So there are 2 chromosomal aspects to be remembered here, that is monosomy 5 and monosomy 7. In contrast, if he says in the MCQ that the person is exposed to another anti-cancer drug, that would be topoisomerase 2 inhibitors. In those circumstances, the time it will take for the development of acute myeloid leukemia will be relatively lesser. In fact, we have seen that as early as within 1 to 3 years of exposure to topoisomerase 2 inhibitors, this chap is going to end up with development of acute myeloid leukemia, and the chromosome involved in this particular case would be chromosome number 11. Now, I know the query from you would be, sir, how am I expected to remember all this information? Then all I want you to do is just look at some numbers there carefully. I mean, if you look at numbers 4, 5, 6, 7, right, a sequence. And if you look inferiorly, the sequence that you will see here will be 2, that is topoisomerase 2 inhibitor. So 1, 2, 3, right? And then another 1 added, that is chromosome number 11. So if you just have a look at these numbers, I think you can remember it here. 4, 5, 6, 7 alkylating agent aspect, whereas 1, 2, 3, 11, I mean a sequence, right? And then 11, that would be related to topoisomerase 2 inhibitor. So point number 5 is important from the exam perspective in a sense that he can switch the data, he can invert the data, he can write the opposite information for the chromosomal aspects, he can write opposite with respect to the time it will take for the development of this cancer. Let's look at another cause which is to be remembered, that would be radiation exposure. I have already sensitized you to the fact that radiation exposure can cause development of all blood cancers except CLL. Then would be from the petrochemical industry, that is exposure to benzene. 2 drugs which are to be remembered is phenylbutazone and chloramphenicol. In fact, chloramphenicol is what I think you would be more comfortable with, because all of you have read in pharmacology with respect to gray baby syndrome. So what I am adding here is chloramphenicol not only is responsible for development of aplastic anemia, but even acute myeloid leukemia, bone marrow failure can develop in these patients subsequently. Now we will study regarding what our examiners love to ask, that is chromosomal swaps responsible for development of this hematological malignancy. So T15 to 70 will definitely be taking its due importance. In this particular case, there will be a formation of a novel oncogene by the name of PML-RARA. The problem with this PML-RARA would be that it will cause a development of differentiation block. So most of the time, the question that will be asked here will be that the differentiation block is occurring at what level? What basically it means is that promyelocytes are not gonna differentiate. Because I said there's a differentiation block here only when cell line will be multiplying one again and again, that is only promyelocytes will be multiplying. Contrast this with chronic myeloid leukemia. In CML I talked about shift to left, so all the precursors were multiplying with the myeloid series, but in this particular case there is a maturational arrest occurring, so it is going to be only one cell that will be multiplying again and again, in contrast to CML as I explained the shift to left manifestations. Now, for treatment of these patients, currently we are not using cytarabine, because what was happening, and please don't note it down what I say next, this is only for explaining to you that earlier when we used cytarabine, what we found was that the DIC risk was increased. However, currently I'm erasing information now for the management of these patients, what we are rather doing is that we are trying to make this bad guy, promyelocyte, give a chance for reform, a chance for improvement. You see, what I'm saying is, there's a bad guy, either you tell him, we are going to send in the police force and we're going to kill you, that is chemotherapy is going to kill you, but the bad news is, because there is risk of DIC, innocents also getting involved, so I give this guy an opportunity, the bad guy, okay, I'm going to give you a chance of reform. What I mean by reform here is that we are giving this cell an opportunity to differentiate. Now the molecule which has been shown to cause the chances of improvement or differentiation of this cell is all-trans retinoic acid, and because the cell will differentiate, obviously there are some disadvantages of that also, but at least what you have done in this particular case is you have changed the entire, I would say, the profile of the disease, where one bad guy was running the show from giving an opportunity to reform, and now rather some mature cells will start forming in the circulation. In fact, this is, I would say, a very revolutionary concept with respect to management of promyelocytic leukemia, primarily because of the bad prognosis that we were having with respect to this particular chromosomal translocation. Another chromosomal translocation that they love to ask is 8:21. Now I'm putting an old name, I'll erase this name subsequently, because nowadays the medical literature does not support the use of the word chloroma. Nowadays the word that is used is myeloid sarcoma, but it presents as, I think if you're using the older version of even pathology books, you will notice an image of a child with unilateral proptosis, a kid with a big eye, unilateral proptosis, that is chloroma. So chloroma is related to T8:21 translocation. Because it's an old term, I have erased the name here. The current name I'll write subsequently in the clinical domain is myeloid sarcoma. The chromosomal swap in this case will result in development of, again, I said, a fusion product, and let's look at the name for the fusion product, pretty fancy name, that is RUNX1, X1T1. So they expect you to remember these fancy aspects also. Apart from this inversion of chromosome 16, then is again a chromosomal 16 translocation is responsible for the pathogenesis. if they want to talk about the gene, there are many of them that I'll tell you, but one of the special genes that they will always ask you, and the figure given for this in Harrison is as much as 30% cases of acute myeloid leukemia would be having a FLT-ITD activating mutation. This is in fact the commonest gene which is to be answered with respect to development of this cancer. Apart from this, I've talked about even RUNX X1T1. I've also spoken regarding PML RARA, a special novel oncogene which is being produced in these patients. So what I'll do next will be that I'll compile a small list before you where I'll be mentioning regarding some mutations and some chromosomes which are associated with favorable prognosis in a patient of acute myeloid leukemia. And the first one here will be FLT3-ITD. I have already spoken about it, saying that this is related to, it's an activating mutation and it's related to 30% of patients of acute myeloid leukemia having a favorable prognosis. ITD basically stands for internal tandem duplication. Not that it's very, very important, but still wherever possible, if the data is given in italics and is highlighted in the textbook, I am just trying to mention it here. The two more mutations to be remembered would be CEBPA, and the third one to be remembered is NPM1. And why am I asking you to remember this is because of the following fact. Just pay attention to the screen at the moment. Do not note down anything. Just listen to the words that I'm saying. You will notice that sometimes in the MCQ, he will write FLT3-ITD, same as what I wrote, but then there will be a superscript mentioned. In the superscript, it will be written high. And once you read the superscript present, then your answer will change. This is going to be related with a poor prognosis. So you just need to catch this word so that you are able to answer the question relatively better. As far as the chromosomal aspects are concerned, I usually find people not making a mistake because they have read about this in pathology also. So you do read about T8 to 21 being associated with the chloroma, but then this is associated with a favorable prognosis. The new name for chloroma is granulocytic sarcoma. The second favorable prognosis would be inversion of chromosome 16. So 16 chromosome coming up here again for another translocation called T16:16. This that I have mentioned here before you is a summary of, though it's widely separated points which are given in the textbook. In the theory part, I've just compiled a list at a single place with respect to favorable prognosis in a chap with acute myeloid leukemia. And next we'll talk about what are the clinical manifestations, and anyway the person will have to undergo chemotherapy. Now, you know, a big problem with chemotherapy can be superficial thrombophlebitis. I mean, getting a prick and then developing thrombophlebitis is anyway going to be an emotional trauma, and God forbid if there is an extravasation, there would still be more problems for the patient. So before I describe clinical manifestations here, I've simply put up an image before you. This was an image-based question, and as all of you can recognize, this actually represents a chemoport. You can deploy this chemoport in the superior vena cava of the patient. So every time you need to give an injection, you will give it into this particular area where I put the red mark, and the drug will directly go towards the heart. So you are bypassing the risk of superficial thrombophlebitis. You are anyway minimizing the risk of extravasation of anti-cancer drugs, which can cause an extensive ulceration in the hand of the patient. So we are trying to make life a little better for these patients. The next image that I'll show you is not for acute myeloid leukemia, absolutely not for acute myeloid leukemia. This is just simply a statement which is from the context that as I was teaching you, we can deliver drugs directly into the great veins of the heart. We can deliver drugs directly into the CSF of the patient. Like if a patient is having a craniospinal axis involvement, if a person is having leptomeningeal metastasis, or rather a person is having a CNS metastasis, and the cancer has spread via the CSF. So I can deliver the drug directly into the CSF as well. This that I've shown before you, where you can give an injection directly into the CSF of the patient, and I'm very sure you would have read about it, is called as Ommaya reservoir. So these are two, I would say, devices which are used in patients who are having hematological malignancies to deliver the drug and make the life of the patient relatively better, because otherwise you will anyway have to do a lumbar puncture and go in for an intrathecal administration of an anti-cancer drug. But then enduring a lumbar puncture every time on a regular basis would anyway be an emotional trauma for the person. Coming to the clinical presentation of the disease, this patient would be having an age group of about 65 years of age, and the disease has a stormy onset that the deterioration will occur in as fast as 3 months. The initial complaints of these patients will mainly be non-specific, that is fatigue and weight loss, and along with this there will also be fever. And I'm not saying that initially there is going to be some infection developing in this patient which is causing development of this fever. It's just a manifestation of the catabolic process that is occurring in the body, because ultimately a lot of cancer cells are being produced and they're getting destroyed also. So cytokines can be produced, interleukin 1 can be produced, and low to moderate grade fever can be present in these patients. Subsequently, as the disease manifestations will become very florid, the TLC of this patient might skyrocket, and there is a possibility that he might give you an outrageous value of TLC of something in the range of about 1 lakh per cubic millimeter. Now, this is definitely going to contribute to what I mentioned even in the starting of the discussion, that is development of leukostasis. The organs which are involved in leukostasis in decreasing order of importance, I mean, any of them can be involved, but what we have seen is persons would be having respiratory distress and the GCS, so the patient will reduce. So lung can be involved, brain can be involved, then can be priapism, and then even retinal circulation can be involved. So there can be a thrombosis contributing to blindness. As the disease will progress, thrombocytopenia will also occur. Why? Because all the space in the bone marrow will be taken by a cell that is having a maturational arrest. Therefore, megakaryoblast will not be able to perform to their optimal function, and this is when things turn really nasty or bad, because there would be petechiae which will initially appear around the ankles of the person. So I don't expect a old man to look at his ankles and notice the petechiae. So this is what you will notice on your general physical examination. But why he will come to you will be primarily because of the recurrent episodes of nasal bleeds, for which they might have seen an ENT doctor, but initially the ENT doctor gave up and said go and show a physician, and there would be bruises or they would be purpuras. Purpura means palpable bleed in the skin. The progression of the disease will also cause a substantial amount of lymphadenopathy. If I'm talking about a hilar lymphadenopathy, it could be pressing on the airways, contributing to cough, and in the later stages of the disease, even hepatosplenomegaly will develop. One of the very characteristic manifestations that you see in acute myeloid leukemia, and they love to ask about it in the exam, is gingival involvement. We read about gingival hyperplasia developing in this patient, and from the exam perspective they will ask you, this is commonly seen with, so your answer would be, it is commonly seen with M5 variety, that is acute monocytic leukemia. I know that in pathology they will mention M4 myelomonocytic, but in Harrison they have mentioned primarily M5. So I would suggest you that for this particular question, I mean for everything else when it comes to pathogenesis of a disease, I would like you to follow what the pathologist is saying. But if he specifically mentions about gingival involvement in a patient of acute myeloid leukemia, and M4 and M5 both are given, I understand there is going to be some disparity between the subjects, but I would like you to answer it as M5 variety of acute myeloid leukemia. Another manifestation that I want you to remember for this disease would be development of a chloroma. As I've told you, this term is now not recommended to be mentioned in the books, though this will present as unilateral proptosis in a patient. The alternative name which is recommended is granulocytic sarcoma. In fact, not only it can cause a unilateral proptosis, as I was mentioning earlier, but granulocytic sarcomas can also contribute to development of spinal cord involvement. So it is no big deal that you will read about paraplegia. Looks surprising, but true. Neurological manifestation developing in this patient. What I have highlighted is that in some cases you could even be having a spinal granulocytic sarcoma. This is like tumor cells. You see, there are so much of tumor cells in the body that they getting deposited in the periorbital skin, causing a proptosis. There are so much of tumor load that they are having a gingival involvement, a gingival hyperplasia is occurring, and even they can be deposited where the spinal nerve roots are coming out. So pressure on the spinal nerve roots can contribute to neurological manifestations in these patients. Point number 6, 7 and 8 that I've highlighted for the disease, I'll just go back to the slide. 6 I mentioned was gingival involvement, then chloroma association and DIC are one of the important reasons why this exam would ask you about them, and they definitely will love to incorporate the chromosomal associations here. Chloromas are more common with T8:21 translocation, whereas DIC is more common with 15:17 translocation, which is M3 variety and is also written as acute promyelocytic leukemia. Just like in acute lymphoblastic leukemia, you will notice that he'll talk about child, and then we'll obviously talk about, development of anemia, bleeding, and hepatosplenomegaly. I mean, these three features that I'm saying: anemia, development of petechiae, and hepatosplenomegaly. This is what is very characteristic for any acute leukemia. But then there are special features of acute lymphoblastic leukemia, which I'm incorporating here for just comparison in the multiple choice question, because they are very characteristic for this disease. One is that the immature cells here can cross the blood-brain barrier, and therefore you can have a CNS leukemia. It is not that CNS leukemia can't be seen with AML, can be seen, but is rather more common with acute lymphoblastic leukemia. And even the cancer cells can cross the blood testis barrier. You see, you read about testicular cancer going everywhere, but here I'm teaching you a hematological malignancy is going via the blood testis barrier and is contributing to a development of a testicular lump. So if you get this kind of a profile where I'm talking about a KID, hematological manifestations, organomegaly, and these 2 points written given, then obviously investigations have to be done, but the clinical diagnosis should be in the favor of ALL. Whereas if you get a geriatric age population with mentions like gingival involvement or granulocytic sarcoma, paraplegia, and even a DIC risk, then you should think in terms of acute myeloid leukemia. And anyway, I'm not saying that age is the one that will decide. It is the clinical features that will make you suspect that, okay, this is the malignancy that could be present. And now we will talk about the workup of these patients, which will definitely involve a bone marrow aspiration. So I'll definitely show you the needles that we're gonna use for a bone marrow aspiration, but just let's look at some diagnostic criteria at this particular juncture on this slide. If I do a bone marrow aspiration in these patients at the posterior superior iliac spine, I can do it at multiple sites. This is the recommended one. Then the percentage of blasts, that is myeloblasts in the bone marrow, should be demonstrated to be more than 20%. But there is a if here, and that if is to be remembered. If in a question he is going to mention about some chromosomal abnormalities, which I have already enumerated, is just a repetition, but if these chromosomal abnormalities are given in a question, even if, mark my words there, if these chromosomal abnormalities are given in the question, even if in the bone marrow the blast concentration is less than 20%, you can still make a diagnosis of acute myeloid leukemia. I repeat the fact once again, the cutoff is 20% uniform. But if the following chromosomal swaps that I'm mentioning before you, they have already been talked about, I'm just reiterating the fact that if you are able to demonstrate this with help of karyotyping and even a FISH, then your job is done. I mean, you don't need to wait for the cutoff of 20% to be achieved and then declare the person is suffering from acute myeloid leukemia. T15 to 17, 8 is to 21, then is inversion of chromosome 16 and 16-16 swap. If any one of these, I'm saying any one of these are given in a question and the cutoff is given as less than 20%, no issues, you would still answer this as acute myeloid leukemia. Now let us look at what will be the needles that we shall be using for identification or going in for the procedure per se, and then the histopathologist will do his job by looking at the microscopic finding, then go in for flow cytometry and identify and tell us that, okay, this is acute myeloid leukemia. You can see a side screw, a very characteristic side screw, which is shown in this needle. So from the word side screw, I said alphabet S, side screw. This would be Sala's needle, whereas in the needle which is given inferior to this one, you will notice a very characteristic guard present. So this guard will definitely ensure the depth that you can reach, and this would be image for Klima's needle. This is, I think, a repetition from the pathological domain, but anyway, it's my job to speak about them as well. And then inferiorly, what I've shown is a traditional bone marrow biopsy needle. And one fact that is not related to acute myeloid leukemia, but I'm still saying, is that thrombocytopenia is not a contraindication for performing a bone marrow biopsy. I repeat the fact once again, we want to identify why is there a thrombocytopenia in a patient. So even if in a MCQ, platelet count is 40,000 or lesser, I'm just saying a general statement. If platelet count is suppose 40,000, 30,000, and he says, can you perform a bone marrow biopsy in the patient? Then the answer is yes. Platelet count lesser is not a contraindication for performing a bone marrow biopsy primarily as a procedure per se. Why? Because you have to identify why is it lesser. It's ultimately a hematological cause in a patient. Now, once we have done the procedure, I'll send the sample to the pathologist's office. So let's look at what are the reports that I'll be getting. And one very characteristic feature would be that myeloblasts are documented and Oyer rods are present. I mean, if you read Oyer rods anyway, I mean, I would say like this, that the diagnosis is anyway confirmed. So in the exam, to have a Oyer rod given to you, that too in a NEET PG entrance exam, is a little unlikely, because I think that will make things very easier for everybody, and this is a competitive exam. So yes, I mean, Oyer rods definitely make things relatively easy. If they want to give it, it's okay, even if they don't mention about it, but they would love to talk about these chromosomal swaps, then do remember this information. And now let's look at what will be the lab reports that you will encounter in these patients. First, we'll talk about complete blood counts. So hemoglobin will be lesser, as is common in any hematological malignancy, because normoblasts are not going to be in a position to multiply when the entire colonization of the bone marrow is occurring with a single cell. In the initial part of the disease, TLC will be less. Why TLC would be less? Because it's a maturational arrest. It's a maturational arrest. So therefore, the formation of mature cells will be hampered, and that explains also infections that can develop in these patients in the later part of the disease. But once these immature cells will colonize whole of the bone marrow, they'll come out and colonize even the lymph nodes. There would be a lymphadenopathy. Even in the blood, these TLCs can contribute to mayhem in the form of development of leukostasis in the patient. Platelet count will be lesser, so chances of bleeding are anyway elevated in these patients. You notice that in CML, there is initial presentation of thrombocytosis. In blast crisis, there is a thrombocytopenia, but in AML, right away, there's a thrombocytopenia occurring in a patient, though you do have to remember that TLC is lesser in these patients initially. Why? Because there's a maturational arrest. Now, the investigational choice for these patients will anyway be a bone marrow aspiration, unlike in chronic myeloid leukemia, where I mentioned about FISH. We will be doing a couple of studies on the sample of bone marrow aspiration. So obviously morphological analysis of the cells would be done. Oyer rods can be demonstrated. Apart from this, the sample will be subjected to cytogenetics, because we want to identify whether it's a good or a bad prognosis in a patient, and even the flow cytometric analysis will be done. Just like you guys are comfortable with the report for CLL, I told you CD19, 20, 23, and then even CD5. CD5 is a T cell marker expressed on a B cell for chronic lymphocytic leukemia. Can you tell me here, guys, from your knowledge of pathology, what flow cytometric markers would you be remembering for especially a myeloid series leukemia? I'm talking about acute myeloid leukemia. Yes, guys, you would be remembering that this would be CD13, CD117. And for especially the M7 variety, which is megakardioblastic leukemia seen with Down syndrome, I would like you to remember the CD markers at CD41 and CD61. So do remember these numbers. I mean, I'm sure you would read them in pathology. It's just a matter of being able to recall when I suddenly put up a question before you. So we will be doing a morphological evaluation, cytogenetics, and then the flow cytometric issue here. When it comes to the molecular studies in these patients, in fact, I can write this separately so that it will give me one more opportunity to talk about all those mutations that I was talking about. So we are going to check for FLT3 ITD, that is CEBPA. These would anyway be having a relatively good prognosis, and NPM1. The reason why I wrote it again is just to sensitize you to the fact that these are having a good prognosis. Other investigations that would be required would be like a baseline chest x-ray to check for presentation of lymph nodes. Anyway, he's an old patient, so I also want to know his cardiac status, that is echocardiography, because I want to pick up if he's having maybe a concomitant hypertension, there might be a heart failure with preserved ejection fraction, and the anti-cancer drugs that I'm going to use in this patient during chemotherapy, they will also cause damage to the heart. So baseline echocardiography will anyway be required. Then HLA typing would be required, because we are in future planning a allogenic stem cell transplantation. I also need to run a baseline KFT. Why that is important is because the tumor load here is very, very high. So what really can happen is, if you will give chemotherapy to this person, the good news is cancer cells are dying. The bad news is that the cancer cells can contribute to tumor lysis syndrome. The manifestations of tumor lysis syndrome would be that because of the breakdown of DNA, there will be excess production of uric acid. This uric acid can block the tubules of the kidney, and therefore the crystals of uric acid can even trigger an acute tubular necrosis. Then cancer cells are loaded with phosphate. Phosphate why? Because ATP will be present, and ATP will produce phosphate, and this phosphate will chelate with calcium, so the values of calcium will become lesser. Most of the time they would love to ask about what becomes more and what becomes less. So uric acid is more, phosphate is more, potassium is more, calcium will be lesser, and our objective would be to prevent the deterioration of this person is from occurring. So what we do to prevent tumor lysis syndrome will be one, hydration. In fact, tumor lysis syndrome is discussed separately in the app also, but because this is giving me an opportunity, so I just want to say that whenever you plan to start chemotherapy in any patient, not only in acute myeloid leukemia, in any patient, prior to starting a chemotherapy, adequate hydration should be done so that the kidneys are well perfused, and therefore the chances of kidney shutdown will definitely be lesser. Along with this, because there's a high cell turnover, so I want to give allopurinol for the patient, and if I'm finding no response even with allopurinol, then we might have to use a drug that will break down uric acid, that is rasburicase, for the patients as well. So this would be a list of various investigations that have to be remembered. And as I've told you already, I mean, I don't need to wait for that cutoff of 20% for some chromosomal swaps. That definitely, I mean, the diagnosis can be made at less than 20% also. And now I'll talk about some aspects from pathology before we talk about the treatment of these patients. So from the pathological perspective, what I'm teaching you here is WHO 2016 classification for patients of acute myeloid leukemia, because what I used to read was the FAB classification, the French, American, and the British one. The couple of slight differences, subtle ones, that you need to remember. So whenever you read regarding acute myeloid leukemia and then he prefixes the word recurrent genetic abnormalities, it basically means that he's talking about the chromosomal swaps that I was speaking about earlier, like T88:21 or inversion of chromosome number 16. The next one that I write is definitely important. So I'm using a thicker font here, that is acute promyelocytic leukemia with PML-RARA. That would be the novel oncogene that would be created here. RARA here would stand for retinoic acid receptor alpha, and this APML is anyway related to development of DIC. The third association to be remembered would be acute myeloid leukemia with myelodysplastic MDS changes. The fourth one to be remembered would be acute myeloid leukemia. Then he will write NOS, that means not otherwise specified. The breakup of these subtypes of AML, not otherwise specified, I'll mention on my subsequent slide. Then would be the term myeloid sarcoma. And the third one is what you encounter with especially Down syndrome. So he will say myeloproliferation, which is associated with or is related to Down syndrome. That would be transient TAM is the term that you read in pathology, transient abnormal myelopoiesis. I know the fact that this will sound a little, I would say, overwhelming to remember initially, but then I would suggest you to just note it down once with me, and this will become a second nature for you. And now I will highlight on this particular component, AML not other specified, which can definitely be asked. So let's look at the important subtypes which can be asked to you. One of them would be acute myeloid leukemia with minimal. The words have to be remembered with care. He will say with minimal differentiation. Then is going to be acute myeloid leukemia without maturation. I know in pathology they will talk about M0, M1, then M2 and so on, but what we need to remember here is not from the numbers, but the way he would actually give it to you in the real exam scenario. He will write acute myeloid leukemia with maturation. This is the one that formerly was referred to as the M2 variety and was relatively a common one. So I'll just mention corresponding numbers there also, that is M0, M1, M2. And then we come to the formerly referred as M4 variety, that is acute myelomonocytic leukemia. You see, I have already sensitized you to the fact that this in pathology books is said to be associated with gingival involvement, though in Harrison it is M5 that is mentioned. So let's look at what will be the term that will be for formerly the M5 variety. The word written will be acute monocytic leukemia, or he might write the word monoblastic leukemia as well. I have just highlighted the word myelomonocytic in green, not that it is very important. I've just highlighted the sequence that you need to remember for the exam. It is myelomonocytic, then would be acute monoblastic leukemia. Now the M6 variety was called as erythroleukemia, but now instead of calling it erythroleukemia, he will call it pure erythroid leukemia. M7 was written as acute megakaryocytic. Now it is written as acute megakaryoblast leukemia. This is the one that I showed anyway, highlighted before you, is related to Down syndrome. Two more to go and then the problem would be over. That is acute basophilic leukemia. And the last one is panmyelinosis, little tongue twisting name, panmyelinosis with myelofibrosis. This is the entire table, guys, which I have mentioned over the two slides before you, and I would like you to specially remember the ones in front of which I mentioned these numbers also. That is the names to be remembered from the current discussion would be M2, then would be M5 and M7. Why M2? Because this you study in pathology also happens to be the common variety, though highest concentration of iron rods are seen with M3 variety. And I told you with M3 variety, when you kill it, the promyelocytic leukemia one, there's a high risk of development of DIC in the patient also. M5 has been highlighted a couple of times for gingiva, so I think this is second nature for you. Down syndrome aspect you anyway knew, so I introduced a gene here also initially, and once you get this two slides in place, then we'll talk about the treatment for these patients. For the chemotherapeutic drugs that would be recommended for management of acute myeloid leukemia, the first answer of yours would be cytarabine. Along with this, we can be using any of the two anthracyclines that I'll be mentioning before you. Please do take care of the fact that initially I had told you that alkylating agents, the word was alkylating agents, can trigger to AML. Now I'm treating it with anthracyclines. There are two of them and any of the two can be used. One is daunorubicin. The second one to be remembered would be idarubicin. Now they both can be having problems with respect to damage to the heart. They could definitely contribute to cardiotoxicity also. So that side effect definitely has to be remembered, because we are talking about an old person and he could anyway be having a compromised cardiac function in place. For the M3 variety of acute myeloid leukemia, we will be using ATRA, that is all trans retinoic acid. I mean, you can see for this cancer that was causing mayhem with respect to development of DIC, we are not using any fancy molecule which was developed and is a multi-million-dollar drug, but something as simple as a vitamin E derivative. This is itself, I would say, a very revolutionary thought process, that we are using a vitamin E derivative, and the advantage of this would be that why do we give it is because it is causing differentiation of that abnormal cell into mature cells. So what you are doing is you are giving an opportunity for redemption, or I said rehabilitation, of these cancer cells. I mean, he's a stubborn bad guy, but you're telling this bad guy, see, we are gonna hit you, we are gonna kill you. So instead of this, we are giving an opportunity to behave. What I mean by behave is differentiate into the subsequent cell series. So therefore, this is a totally different approach where we are allowing the cancer cells to go into a much more evolved form. There's a differentiation into the subsequent series of neoplastic cells, and then subsequently what will happen is, if there's a differentiation, no, they will die. I mean, that is what I want. No, I want the cells to die just like normal cells. In your and my body, cells are being produced, cells are dying. So ultimately what I want to achieve in these patients is written as senescence. Senescence means that ultimately the cells will die. This is my objective and I'm able to achieve it. There is senescence of the leukemia cells. But there's a problem. Now let's look at the problem. The problem is that cells will obviously differentiate, but the cells which are produced here are a little sticky, so they adhere to the pulmonary endothelium and they start releasing cytokines which cause damage to the pulmonary endothelium. If the pulmonary endothelium will be damaged, there would be leakage of fluid into the alveoli, and therefore this person, because of the cytokine release and the direct damage caused by these cells, will end up with development of respiratory distress. And this was a question that was asked in the yesteryears in the exam, that you have treated a patient of M3 variety of acute myeloid leukemia with ATRA and is having respiratory distress. What could be the etiology? One thought process is simply the fact that any blood cancer patient could have developed an infection. It could be a viral pneumonia, fungal pneumonia. It could be something like COVID-19 pneumonia. So any person who's having respiratory distress and is a blood cancer patient, I will definitely think in terms of possibility of a cancer patient ending up with pneumonia. But in this particular case, you have to give importance to the history which is given, that ATRA was given, and when ATRA is given, I mean, this part is obviously not given in the question. He's simply going to say, following ATRA, there's a distress. What you as a physician is understanding is that ATRA is causing differentiation, and therefore there's causing it's causing lung damage also. So the term that we use here is called as differentiation syndrome. Options were like viral pneumonia, fungal pneumonia, differentiation syndrome. Answer is differentiation syndrome. And in another year, he asked what will be the treatment for this patient. So because we're talking about cytokines, obviously supplemental oxygen will be given to these patients, but the mainstay of treatment will anyway be steroids. So do remember, you are giving steroids to a patient who has just received anti-cancer drugs. So opportunistic infections can anyway come in, but at the moment I'm more worried about the release of cytokines. So therefore it is the steroids which are the first step management for differentiation syndrome. I repeat the fact once again, if an acute myeloid leukemia patient is not treated and is having development of respiratory distress, you think in terms of leukostasis. But if he is treated and there is a distress, you think in terms of a possibility of differentiation syndrome in the patient. And overall, if I say what is the most common acute leukemia in adult patients, like you are aware of the fact that the most common acute leukemia in pediatric patients is acute lymphoblastic leukemia, but the commonest acute leukemia in adult patients is the topic that I've just explained to you, that is acute myeloid leukemia. And what is the role of allogenic stem cell transplantation of these patients? So this is what Harrison says. Allogenic stem cell transplantation can be done after proper candidate selection, and it is mainly a relapse prevention strategy. So first you will anyway have to go in for management of these patients with chemotherapy to prevent any kind of a relapse. Subsequently, if resources are available, donor is available, HLA matching is done properly, then yes, allogenic stem cell transplantation can be done in these patients. From the exam perspective, they will mainly ask you regarding the aspects related to ATRA, and also another drug which I'm now mentioning. I had said it verbally initially, I'm just mentioning the name at the moment, that is arsenic trioxide. I mean, this is again very surprising because the forensic doctor will always say most common homicidal poison is arsenic, and look at what we are doing here. We are prescribing arsenic to a person with a blood cancer. So because of this unconventional approach to the management of this cancer, this information needs to be remembered. These are the details for this topic that I wanted to remember. So thank you so much for watching. Keep hammering, keep the focus on, and you'll definitely be able to clear the exam with flying colors.